And that gives us the opportunity to see trajectories and to have like experience in these co-occurring conditions that I will talk about. So today I was thinking that I have a lot of participants from the prior talk when we discussed in depth autism, diagnosis, epidemiology, and genetics. And so Maria and I decided I would focus more on the co-occurring conditions with autism spectrum disorder. So you're not going to hear a lot about how the epidemiology of autism, what is the, how do we diagnose autism, genetics of autism. I'm just going to focus on the co-occurring conditions. We want to make this as interactive as possible, so free to chime in if you have questions. So if you look at the literature, the co-occurring conditions with autism are divided in general medical, developmental, behavioral issues, and psychiatric. I, as a developmental behavioral pediatrician, I do a lot of psychopharmacology because a lot of my patients are, as you're gonna see, ADHD, anxiety, mood dysregulation. So I have the opportunity to treat them. Something I want to tell you ahead of time is I'm not going to cover all the topics the same. I'm going to prioritize some. There are some like speech language disorders that I think there are other opportunities. There are other people that can talk more about that. Okay, so let's. So medical co-occurring conditions. Is that a question? Oops.
Oh, sorry. No, we were going to put a poll here, but we can go right ahead.
Okay. So, okay. So we're going to start with medical co-occurring conditions. These are the most common medical co-occurring conditions: gastrointestinal, epilepsy, sleep disorders, immune dysregulation, and genetic conditions. And these are, these are the frequencies. So you can see there are these wide ranges, and the wide ranges are because the literature classifications for these conditions, different criteria, and there are also, over the years, there have been different classifications for like autism. So that's the reason we range. But the more common ones are gastrointestinal, epilepsy, and sleep disorders. And those are the ones that I'm gonna focus on more. Something that is important to keep in mind, particularly in kids that have autism that present sudden emotional behavioral dysregulation, think about pain, like dental problems, food allergies, minor injuries, ear infections, and headaches. Those are all common conditions that may come up, particularly with acute behavioral emotions. And that's something that we as clinicians, we need to think about. So medical disorders in children with autism are widespread and come across different areas like immunology, neurology, and gastroenterology. Like I mentioned before, it's a wide range of percentages because it's challenging to these categories and also the autism samples. Something to keep in mind is gastrointestinal disorders increase the risk for seizures and sleep problems. Sleep problems increase the risk for gastrointestinal disorders and seizures, but seizures do not increase the risk for gastrointestinal disorders or sleep disorders. Something that is really important, and I have lived that in my experiences, many children that have a lot of gastrointestinal, seizure, and sleep problems are going to have more adaptive, more behavioral symptoms. So it's really important. I recall, this kiddo that has significant autism, like a moderate to severe autism. This kid had 4 or 5 years. He had a lot of regulation. He was not available to his therapists. And when I got the history, he was having a lot of breathing difficulties and was having a lot of sleep problems. And he also had constipation. So Sometimes this is, this is a kid that is getting many hours of ABA, speech occupational therapy, and is not responding, he's irritable. And what we did is we focused on improving the constipation and improving the sleep. And once we achieved that, he still had autism, and he still had a moderate autism, but he started being more available, and he was not having a lot of disruption. So, so that made a big difference, and I think that's something. I think that's a great example how these conditions can impact the function and availability of these young children. Let's go to the next. So let's dive in a bit into the gastrointestinal symptoms in children with autism. So the more common symptoms that we see in children with autism in the gastrointestinal area are constipation. A lot of kids have constipation. And something we need to remember is constipation can cause pain, can cause decreased appetite and decreased food intake. So it's really important to keep an eye for us clinicians, for parents, and for you that are also working with these children. If there's constipation, that's something that could be causing problems. Abdominal pain is also a common complaint, and again, often is related to constipation. Actually, I would say the most common cause of abdominal pain in young children might be constipation, statistically speaking. So there can also be chronic diarrhea, and the other offender for gastrointestinal issues in young children is reflux. Reflux can be causing a lot of decreased appetite, a lot of abdominal pain, and irritability. And it's really important to think about that. And sometimes, we think about reflux when we usually think about reflux when these symptoms tend to correlate with food intake, when this is just after feeding. And I've seen some kids that have so much reflux associated with feedings that they don't want to eat because they want to prevent that pain that comes when they eat. There are other conditions like gastritis, esophagitis, inflammatory bowel disease, celiac disease, Crohn's disease, and colitis that can be associated with autism. But I think these are ones that we need to think more about. Something that I want to say is that there's a big correlation between behavioral signs such as anxiety, aggression, and dysregulation, and the increase in the frequency of gastrointestinal disorders. So it's really important for us, for all who work with these children, if there are gastrointestinal symptoms, to try to deal with them. First with the primary care physician, but if it's a more complicated condition, which often is in kids with autism, they may need to be referred to a specialist. I want to show you here some studies that have been written about gastrointestinal symptoms and autism. So this is a cross-sectional study of 140 to 170 with autism. And 24 to 63% of these children had a history of a GI symptom, which is, a lot. It's 1/4 to 2/3, almost 2/3 of the children with autism had either diarrhea, unformed stools, constipation, bloating, and reflux. Then we have this other study, which is 150 children that were studied. 50 had autism, 50 had developmental delays, and 50 had controls. So 70% of the children had GI symptoms compared with 42 developmental delay children and 28% controls. So this tells us that, children with developmental delays have more risk than typically developing children for gastrointestinal symptoms, but that's even higher in children that have autism. So we need to have a high index of suspicion. And this is a very interesting study of 124 children and 2 matched controls for each kid that were followed for 18 years. And something that is interesting is that there was no long-term increase in the GI diseases or inflammatory or malabsorption problems. So they didn't have higher risk for celiac disease. They didn't have higher risk for Crohn's disease, or, significant problems. But what they had is the big significant difference was issues with feeding and food selectivity from 24.5% in people with autism versus 16.1% in typically developed children or individuals, and constipation. So the big ones are constipation and food selectivity run. So now I want to move to feeding disorders and autism. So how we define feeding problems is a disorder in which the inability or refusal to orally consume adequate nutritional, hydration, or caloric intake in the amounts required to thrive results in negative nutritional, developmental, social, and psychological consequences. So these are kids that are not eating enough and it's having an impact in their life. So if you look at the literature for feeding disorders, studies in the 70s show 6 to 33%, but more recent studies show that the prevalence is probably higher. It's more like 13 to 80%. And again, we have the big range. There are different studies have different definitions of feeding disorders, and they study different autism populations, like kids that are clinic, regular clinic, versus like a general pediatric clinic, versus kids that go to a specialty clinic or kids that go to psychiatric clinics. So those kids can have different prevalences of these conditions. So what causes that kids have these feeding problems? What causes autism kids to have feeding problems? So sensory processing deficits and food selectivity is a big one. And everybody that works with kids with autism knows that 78% of children with autism have sensory impairment, and that has been corroborated in the literature. And that's a factor. So it's really important to address these sensory processing deficits in kids that have problems. Many kids have skill deficits. Many kids with autism have oral motor delays, which affect their ability to chew, suck, swallow. And also, like I mentioned before, the gastrointestinal disorders. Like I showed, there's a high prevalence of gastrointestinal problems in children with autism. And it's really important to think, evaluate, diagnose, and treat these conditions. I think there are many kids in the community that have feeding issues that go on the radar because they are not diagnosed and treated for both constipation and reflux. And I think, you can have a role in that, particularly if you see some clients of yours that are having feeding issues, recommending parents to go to a clinician. If these symptoms are persistent, ask for like a gastroenterology consultation. So how do these feeding problems present? They can present with food selectivity. They can, disruptive mealtime behaviors. This can be very stressful for parents because, a primary function of a parent is to feed their child. And when children are having a hard time eating, that can be very stressful, and that can be like a vicious circle of stress at home. I have seen some kids start refusing to eat, which are those like more extreme cases, but there are, different degrees of food refusal. And many times kids with autism have limited for food repertoire and have a restricted intake. So if you look at the literature, the two most common feeding disorders are in kids with are the avoidant restricted food intake disorder for all the causes that I mentioned before. And there's also the Spica or rumination disorder. And I want to a little more into, so we're now, let me see, we're going to have a different slide here. Okay, so let's go to food selectivity. So selective eaters, they show aversions to specific food colors, textures, smell, or other food characteristics. These are the GI disorders, and all these food selectivity may adversely affect diet quality, nutritional deficiency, can cause nutritional deficiency, and can affect the gut, bacteria in our gut, and all these selectivity foods, all these GI disorders can cause a change in the bacteria we have in our gut. However, there's a lot talked about gastrointestinal issues, diet issues, impact of that in the autism symptoms, but at this time we don't have enough knowledge to decipher how could feeding and gastrointestinal issues are linked to autism. So I want to talk a little bit about pica. Pica is the eating of non-nutritive, non-substance that is persistent over a period of at least 1 month. And it's inappropriate mental level of individuals, and it's not part of the culture. So, what caused pica? So it looks like there can be some micronutrient deficiencies like iron deficiency, calcium deficiency, and zinc deficiency that many times can be in pica. But something that we see is a lot of kids with neurodevelopmental disabilities, including autism, have more pica. And could these neurodevelopmental disorders cause pica? And what people are thinking, not necessarily. It looks like somehow these individuals with neurodevelopmental disabilities are more prone to have pica, but pica is more like a behavioral disorder. It's something that some kids with neurodevelopmental disorders learn. In some cases, pica in children has been associated with deprivation, parental neglect, but not with everybody. And it may present as a consistent psychiatric disorder, like with anxiety or with ADHD. So there's more and more evidence that there are some conditions that lead to malabsorption and malnutrition or anemia that can be causing pica. So pica should be investigated first by the primary care physician looking for nutritional deficiencies. And if needed, these kids should go to see a specialist. So it's really important to look for anemia. When a kid has pica, look for anemia, iron deficiency, the blood lead levels, infections and parasites, and bowel and dental problems. And this requires a multidisciplinary approach with physicians, social worker, dietitians, psychologists, occupational therapists. So everybody needs to be part of the team to treat this complex condition. So feeding disorder cause malnutrition, can cause malnutrition, can cause vitamin and mineral deficiencies like lower calcium and iron deficiency. In kids, it doesn't cause low weight, but overweight, because particularly older kids with autism, there's a tendency to eat fatty foods, and there's a risk for obesity. And something that we need to keep in mind that can be very disruptive to the life of children and families is there can be a lot of invasive medical when kids have feeding disorders. Like they get tubes, they get admitted to the hospital, conditions of failure to thrive. They get procedures like endoscopies, colonoscopies. So that can be very disruptive to the life of these children and families. So there's a question here from Grace saying, does licking metal and putting metal objects or other non-food objects in mouth, but not always swallowing, count as pica? Yeah, like, putting a lot of, it depends how frequent is this. But if this is very pervasive throughout the day for more than a month, that may count as pica. Diet interventions in autism. So now we hear a lot about dietary interventions, and there's the gluten-free, casein-free diet, ketogenic diet, the specific carbohydrate diet, and the Mediterranean diet. Unfortunately, there's not enough evidence for these diets. I want to dive in a little bit in gluten-free, casein-free diet, which is the we hear the most. I have even seen some physicians recommend this diet. So what is the exclusion of all gluten-containing food items, which we all know the gluten-containing, and the casein means no intake of dairy products. And so we recommend this diet for people that have allergies or allergic to gluten and casein, regardless of them having autism or not. For people with autism, there's some conflicting evidence. There are some studies that say, yeah, it may be better for the bowel, and that can have a positive impact in the functioning of individuals with autism. But then there are other studies that show, no, if you do a casein-free, gluten-free diet, you're going to have more fiber, and then you have more constipation, and that can be detrimental to this child. So at this time, we don't have enough evidence to support or refute this diet, but there are many studies going on trying to tease that out. What I personally in my practice? In my practice, when families come and say, hey, we want to try this diet, what do you think? And I said, I don't think there's evidence, but feel strongly about doing this diet. I think it's important that you talk to a dietitian to make sure you are meeting the nutritional needs of, and then you can try this diet for 3 months and then see what happens. And then after 3 months, you can introduce gradually gluten food and later casein foods and see if that makes a difference in the function of your child. And then decide, based on that, decide if this is something that you want your child through on an ongoing basis. So that's my take on this. So I wanted to talk a little bit about this, the gut-brain axis. So there are studies that show that many autism children the bowel is more permeable. They have some changes in the bacteria in the gut, and they seem to have some gut infection with a particular bacteria. And people have hypothesized that there are some pathways that can contribute to autism. It has been proposed that there are some cytokines, which are some inflammatory molecules associated with autism due to an inflamed gastrointestinal tract, an inflamed gut. But because this is inflamed, these inflammatory substances may cross all the way to the brain and help an immune response in the brain, influencing autism symptoms and behavior. They also talk about how the different bacteria in the gut for children with autism can play a role in all of these. Like, there are some substances that come up that go all the way to the brain, and that the bacteria in the gut has a role on that. So that's this hypothesis. So I was talking to a colleague of mine here at Rush, and asked him, what does he think about all of this? I actually shared a couple with him. And he told me that in the gastroenterology conferences, there's a lot of research going on about this. This is like a hot topic in gastroenterology, and people are doing a lot of research, but his experience, his knowledge tells him that this is not totally clear yet. So this is still a hypothesis. So there's not enough evidence or demonstrations for this at this time. So he doesn't really strongly recommend trying this or that, but there may be things to come in the next few years. So now I'm gonna switch gears to talk about epilepsy and autism. So the estimated prevalence of epilepsy and autism is 12.1%, which is a lot. And why is it that kids with autism have a higher prevalence of epilepsy? So looks like point, and I mentioned this in my prior presentation, there's a lot of overlap in the genes that cause autism, meaning the genes that cause autism can also predispose children to have seizures and can also predispose children to have intellectual disabilities. So there's, sometimes people talk about, you know, we make such an effort to differentiate autism, but there's a lot of overlap between these neurodevelopmental disorders, autism, epilepsy, and intellectual disabilities. And they share many genes, autosomal abnormalities. The other thing to keep in mind is any insult to the brain via maternal infections or severe neonatal jaundice or any other brain damage predisposes children to have seizures. And also any insult to the brain is going to predispose kids to autism. So that's the explanation why there's such a high prevalence for epilepsy in oops, I think. So, there's increased frequency of epilepsy in individuals with that, in addition to autism, have intellectual disability or genetic syndromes. Females with autism, interestingly, have almost double prevalence compared to males with autism. And there are two ages for epilepsy. One is when children are very young, and one is in adolescence. So those are the two peaks for epilepsy in general, in children, in general individuals, but that is present also in individuals with autism. And it has been found that symptoms of autism can be minimized when epilepsy. So it's something that is really important to keep in mind. I kind of said this at the beginning of the presentation. All these conditions pose like a burden to these children and make them have more severe impairments. So if a kid with autism on top of that has epilepsy that is not well controlled, that kid is not going to function well. So if we are able to achieve good control of the seizure disorder, then this child may do better. Something to keep in mind is sometimes the medications to control the seizures can cause side effects as well and can also bring down their overall functioning. The question here about why do females have more prevalence of epilepsy? I don't have a good answer for that. This is in the literature, but I don't think we have a good answer for why is it that females have higher prevalence, which is interesting, right? Because females in general to have less frequent autism compared to males, and they tend to have like a milder presentation for autism. They can, in general, there are some girls like more severe autism, but the majority of girls tend to have milder autism. I'm gonna try to look for that answer. I'm gonna see, because I haven't come up with an explanation for that. If I do, I'll send an email to Maria. So now I would like to move to sleep disorders and autism. So sleep disorders are probably the most common cause for parents to come to the doctor because that can be really stressful. You know, if the child can sleep well, that impacts the sleep of parents, and parents have to work, and that can be really stressful. So this is one of the prime concerns to seek medical help. The prevalence is really high, 60 to 86%, which is 2 to 3 times greater than typically developing children. And something that we need to remember is that sleep is not only helpful to rest and to be available the next day, but it's also critical for young children for typical synaptic development and brain maturation. And sleep can have detrimental effects on children's cognition in the domain of attention, memory, emotional regulation, and behavior. So So let me see here. So autism can have difficulties staying asleep or falling asleep. So it's, those are the two main concerns from parents. There are studies using like objective measurements of sleep, like a graph is like a watch that you can put on the kid when they go to bed, and using polysomnography, which is kind of like a device that attached to like some leads that go to the kid and that record breathing, brain activity. They have demonstrated that individuals with autism have shorter sleep time, longer sleep latency, meaning they tend to wind down, and they have decreased sleep efficiency as compared to typically developing controls. So something that is really important is why do these kids with autism have so many sleep difficulties? So the sleep problems are multifactorial. So there's no one cause for kids with autism sleep problems. And it varies from kid to kid. But however, something to keep in mind is individuals with autism have underlying logical and behavioral rhythm that predispose them to have a sleep problem. And the sleep problems that they have can be caused by extrinsic or intrinsic stressors that affect their sleep and make them more vulnerable to sleep problems. But what the factors are for each individual kid, all kids with autism have this brain position to have sleep problems. And the factors that can make those sleep difficulties more or less severe are like there can be medical reasons, like gastrointestinal problems, there can be behavioral issues, or there can be cultural mechanisms that somehow in this kid that is predisposed to have sleep difficulties show up more. So that's the reason we have such big prevalence of sleep problems with autism. So the hypotheses regarding intrinsic causes of insomnia in children with autism include, children seem to have brainwave organizational and maturational differences. So you probably have heard about, we all have our circadian rhythm that is coded by some genes. So it looks like people with autism have different things that cause them to have these different circadian rhythms. People with autism appear to produce less melatonin, and they have different arousal, and they also have dysregulation. In addition to that, kids with autism tend to have a higher prevalence of psychiatric disorders like ADHD and anxiety that by themselves cause higher arousal. Now, these are the intrinsic factors, the predisposition, which is not the same for everybody. In some kids, this or that may be more of an issue. But in addition to the intrinsic factors, we also have, so there's the most common extrinsic causes of insomnia are the behavioral insomnias. So the majority of autism difficulties have a sleep association type of insomnia. So meaning they are used to having like a transition object or a transition person to fall asleep. They get quickly at these sleep associations, and that causes often problem. And there are others that have issues with limit setting type of behavioral insomnia, like they resist, they have a hard time falling asleep at nighttime. And so there are predisposing factors for these behavioral insomnias, which can be physiologic, what I mentioned. The majority of kids with autism have brain differences that predispose to have insomnia. But there can also be environmentals. Like, there are sometimes parents that when kids have a hard time falling asleep, they are tired, and they just it's better to sleep, and they start sleep with their children. And that can be a predisposing factor for having chronic symptoms. There can be precipitating factors like if it's a busy environment, if they don't have a good bedtime routine, there can be precipitating factors. There can be like issues at school, when kids go at school or during the day, that can prevent them from winding down in the evening. And there's perpetuating factors for behavioral insomnia, like, when kids fast and they don't fall asleep, maybe parents are sleeping with these kids, like I mentioned, for the predisposing factors, and that's a reward for that kid's behavior. So there can be a number of perpetuating factors for kids to these behavioral insomnias. So, oops. Oh. So I wanted to share with you how the medical practitioners approach these situations. So something's recommended that all children with autism should be screened for sleep problems. Not just with autism, all children, but more so children with autism because they have such high prevalence of sleep problems. It's really important to discuss parental concerns. Where is it, because they live with these kids, so they are the ones that can give you the information. Something that is key is underlying medical conditions that may be contributing to sleep problems. And the underlying medical conditions should be screened and treated. We need to ask for those conditions. The child presents one of those conditions, but because you can do all the behavioral interventions you want, but if the kid has a medical problem, you're not gonna help that kid. And it's really important if you think about behavioral interventions at home, it's important to determine the willingness of the family to implement sleep interventions. There are some families that are great at implementing recommendations, but there are other families that are not available to do that. So the first line of approach is educating parents about environmental modification, positive bedtime routines, and behavioral strategies. So I did we are sharing with you this ATN Autism Network from Autism Speaks. They have a sleep toolkit that was designed experts based on evidence, which can be really helpful for families. But if families are not available to implement this intervention, so in those cases it may be necessary to families to a sleep specialist. Sometimes, you can try to do all interventions, even with families that are very proactive, and still you don't get anywhere. And in those cases, you may want to consider pharmacological interventions. And then the first line intervention is melatonin. So let me go. So it's really important to follow up, and it's important to have ongoing questions for parents. So now I'm seeing that there are, so there's a comment from Susan. This feels super important for us to consider. Many families feel like they are doing everything that is recommended related to sleep environment and nothing is working. It is important for us to be able to share resources related to other underlying issues. Melatonin, arousal, sensory. Thanks for sharing. Thanks, Susan. Are melatonin gummies for kids ever a recommendation to try to help them fall asleep? And I would say melatonin, as I mentioned before, children with autism have deficits in their brain melatonin, which is a substance that is produced to regulate sleep. So melatonin has been found to be very effective. And so I say the only thing is the melatonin over the counter is not regulated. So you don't know for sure how much are children getting. But, I still say it, and I think the large majority of physicians that work with autism use melatonin. It's a standard of care. So I usually recommend for a young child, after trying all the behavioral interventions, I recommend using melatonin. And I usually start with 1 ml, which can be liquid, 1 milligram, 1 ml, or you can try to get, like, I think a gummy melatonin is also an option. Again, there's a little bit of how much of actual melatonin is available. But you can try a gummy, and if that doesn't work, then you can try a liquid one until you find the right formulation. Something that we recommend is if 1 milligram doesn't work, it makes sense to try after a week, try 2 milligrams or even 3 milligrams, depending on the age of the child. And it doesn't work for everybody, I must say. In my experience, it works for like quarters of children, and once in a while, kids can get nightmares or can be a little, quote unquote, irritable in the morning. So in those kids, maybe it's not the answer, but, you know, 3/4, that's a lot of kids. And for such a like very safe and benign intervention. I've heard somebody, Katie says, I've heard the objection that if melatonin is given regularly, the body cuts down it on its own. Is this a valid concern? I don't think so. I have seen many kids that regulate their sleep, and once they regulate their sleep, you can taper the melatonin. And you can, and sometimes you can't. So for some kids, I don't think it's that the melatonin makes them dependent. Giving melatonin makes them dependent. I think it's more that they really need the melatonin, and as they grow older, they are going to continue needing it. But I've seen many where you can taper it down and take it out and use it on an as-needed basis. But these children are always going to have this tendency to have sleep difficulties. So this is a busy slide, all the conditions that can contribute to sleep problems. And this is something we clinicians need to think. There can be gastrointestinal disorders like reflux and constipation, pain. So something that I think is really important is for kids that are nonverbal, that cannot tell you what's going on. You know, it's really important to think about this, even when you know, the reflux can be a tough one when kids are having feeding difficulties or sleeping difficulties. Because sometimes the symptoms, the pain after the meal, which is a symptom of reflux, or the vomiting is not totally clear. Pain is important to think about. It's really important to think about obstructive sleep apnea. We always need to be mindful of kids that are mouth breathers, that snore at bed when they are asleep, and seem to have irregular breathing at sleep. And when we see these symptoms, we need to think about referring these children to the primary care physician for further evaluation. Allergies and asthma need to be treated properly, otherwise they can interfere with sleep. Nutrition, you can be hungry at nighttime. Kids with iron deficiency have high risk of sleep difficulties. Some children are very sensitive to the environment, and there can be some sleep seizures at night. There can be restless leg syndrome, which is associated with iron deficiency. There can be eczema, itching, and dental issues cannot be overlooked. We always need to encourage families to have checkups with dentistry, even if they are like challenging. Here we have, so there's a question from Tanya. She says, can we as EI therapy and melatonin, or should we tell clients to consult their doctors for this? You know, it's an over-the-counter product, so it doesn't need a prescription. I think you can comment that, you know, you are aware that is standard of care for children with autism that have sleep difficulty. This is considered a benign intervention, and that doctors recommend it and that they can try it, but they can consult with their physician to see if they are okay with that. Particularly families, but I've seen many families doing the melatonin without necessarily asking the doctor, and the fact that you can get it over the counter. So many people talk about immune dysregulation and autism. So it has been seen that patients with autism have a higher prevalence of allergies to food and rhinitis, and a prevalence of autoimmune conditions, particularly psoriasis. But having autism doesn't appear to predispose children to have like lupus or rheumatoid arthritis or other immune conditions. But people suspect that there are biological mechanisms between immune mediated conditions and autism that we don't know enough about that. But it's something that people talk about. Genetic disorders, there are like about 10% of people with autism that have some sort of genetic disorders. And these are the most common ones, like Fragile X, Rett syndrome, tuberous sclerosis. In Down syndrome, there are some children that have autism. So there's 10% of kids that look like they have something genetic going on, but we cannot find the genetic problem. And maybe that's because tools are not good enough. But about 20% of kids will consider to have some sort of like signals for a genetic condition, as opposed to 80% of kids that just look like typical kids, that look like any other kid. And so that's important to keep in mind. I'm not gonna dive into genetic disorders today because I wanna go more into the comorbidities and the other comorbidities of autism. So any other questions?
I've been monitoring the chat, and it looks like you've been dealing with the questions as they've come up, so I don't see any new ones. So I think we can continue on and just have folks, as they post their questions, you can decide whether you want to address them in the moment or wait till a break.
Okay. So, so we've talked about general medical conditions. Now we're going to talk about conditions. And I'm going to focus more talking about ADHD, but I want you to see the prevalences. Intellectual disabilities is like 5%. Language disorders is very variable. I would say the majority of kids with autism have late talking at some point, but some kids don't have late talking. And the key language disorder in people with autism is the language pragmatics, regardless of their level of core language skills. ADHD has a high prevalence, 28-44. There's another series that talks about 80%. In my head, I don't know, I somehow think about at least half of the kids with ADHD, with autism have ADHD diagnosis at some point. And then we have tic disorders, 14 to 38%, and then there are motor abnormalities, which is up to 79%. So I'm gonna go briefly on cognitive functioning. So there's a high prevalence of intellectual disabilities in people with autism. But something that is important to keep in mind: not every kid with autism has intellectual disabilities. There are some very smart autism kids. So sometimes they have uneven cognitive skills. Usually psychologists, when they do intelligence testing, they measure the verbal intelligence, the ability to solve problems through communication, through language, and the ability to solve problems through visual spatial skills, nonverbal intelligence. So these are two types of intelligence, and in the majority of people, they are kind of close to each other. But in people with autism, we see a lot of gap between the two of them. And in some kids, the verbal intelligence is a little higher, and in some other kids, the visual spatial intelligence is a little bit higher or much higher. So there's a lot of variation on the percentage of intellectual disability in autism. And that's because there are different definitions for intellectual disability, and there are different populations of autism that are in these studies. So something that I can tell you is there are some kids, usually we consider global developmental delay in young children as kind of like an estimate if the children are going to have intellectual disabilities. Kids with severe developmental delays in the first 3 years of life have high risk for having intellectual disabilities. However, in kids, we need to be very careful because some kids that look very delayed or that at all, that are very delayed in communication or in play or in overall development, clicks when they are 4 to 5 years of age. And then they start looking like they can learn and they can do a lot of things, and they don't fit the criteria of intellectual disability. So I think we need to be careful about, talking about intellectual in the long run. My line for parents when they ask me about this is, it's hard to know where is your kid going to go. Kids follow different trajectories. Some kids do so much better in elementary school, and some other kids don't do as great. So it's different to tell. I usually, when I see strengths, I'm always looking for strengths in my patients. And when I see strengths like social, play, language, I usually try to tap into that to tell them, these strengths, and these strengths make me think of a more trajectory. But again, I cannot tell you how far is your kid going to achieve in the long run. So ADHD and autism. So ADHD is the highest comorbid condition, like psychiatric comorbid condition in kids with autism. And the higher the severity of autism, the higher the chances of more comorbidities. And something that we need to keep in mind is ADHD co-occurrence in kids with autism makes them makes their function worse. So I usually tell parents, your kid has ADHD in addition with autism, and what we see now is the sort of the autism plus the ADHD, but ADHD has the potential to be treated. And if we're able to control the ADHD, your kid may be able to start doing better than what your kid is doing now. And that, I see that as an opportunity. ADHD in autism is much more complex than ADHD in kids that don't have autism, both for diagnosis and for treatment. There are two big types of ADHD. There's like the combined type, hyperactive, impulsive. For those kids, the diagnosis is not that hard because you can see it. Even if the kid has autism, doesn't talk much, you can see that the kid runs like a motor, is up, is impulsive. The really tricky one is when kids don't have the hyperactive component and only have the inattentive ADHD, so they're inattentive. And those symptoms overlap so much with autism that it's really hard to tease. However, there are a lot of kids with autism that have the inattentive type of ADHD. We should try to look for it, and if it's there and we treat it, that kid function at a higher tier. So I wanted to talk, there's some literature on preschools, and you see toddlers up to 3, but I'm sure some of you see preschoolers, and some preschoolers have severe ADHD that have significant behavioral challenges and that are unavailable for therapies because they are so hyperactive, impulsive, and there's not a lot of evidence for treatment. But there's more and more evidence for trying medication in some of these kids, particularly when they are not available for services and they are aggressive to other kids. So, you know, I know that a lot of people feel, oh my gosh, do you want to give medication to a 4-year-old or a 5-year-old? But then on the I think, gosh, if we don't treat these kids, they are not available, and if we could treat them with a safe medication and control this hyperactivity and impulsivity, maybe they could do better. Something I wanna clarify, I wanna disclose, I'm not a happy prescriber, and usually if I'm gonna prescribe a 4-year-old kid, I try other interventions before going there, and I try to make sure that this is something that really is impacting their functioning. But I've seen some cases where it can make a big difference. Kids start talking more, being a little more social, and can be so much better. So I'm not saying all kids with ADHD and autism at 4 and 5 years of age should be treated. The kids functioning is severely impacted is something that should be considered. Tic disorders, there are a lot of kids with autism that have Tourette and other tic disorders. Motor abnormalities are very common, and also motor abnormalities can impact the whole functioning of kids with autism, and I think it's really important to have physical occupation and developmental therapies helping these kids with these areas of functioning. I think kids that have motor coordination problems continue to have motor coordination problems as they grow older, and sometimes the therapies are available as they are in elementary school. So I really encourage parents to try to look for activities that that kids like. Of course, you know, if you're gonna do an activity, the kids need to like it. So they need to be exposed to different activities. Find an activity that the kid is enjoying that promotes motor development. How is ADHD and ASD with meds, mood stabilizers, stimulants? So the two main medication recommendations for ADHD and autism are guanfacine. I like guanfacine. A lot of experience with guanfacine. This is an alpha-2 agonist. So this is a very benign medicine that used to be a high blood pressure medication, and now people use it for ADHD. It tackles primarily hyperactivity and impulsivity. It doesn't tackle attention that much, but for little kids, we don't need that much attention. We just need to take the edge out of them and make them less hyper and less impulsive, and that might be what we need. I have collected data in my clinic for 7 years in treatment responses to guanfacine and stimulants, methylphenidate or Ritalin, and I found that for non-autistic kids, guanfacine and non-autistic schoolers, guanfacine and Ritalin are same efficacy, but for kids with autism and ADHD who are preschoolers, guanfacine seems to be better because it doesn't cause as much irritability. It's not less scary to parents, and doesn't decrease their appetite. Guanfacine has its own side effect, which is it causes tiredness. And 20% of 4 or 5-year-olds that take guanfacine can get too tired with the medicine, so that's not a good option. But for 80%, it can work really well. Yep, that's guanfacine. Questions so far. I'm gonna keep going.
I would, although it looks like Dan had a question earlier. I'm not sure if you attended to that one or not, about children with Wartensburg tend to also have ASD. I don't know if you saw that.
I'm not sure about Wartensburg and ASD. I don't have an answer for that now. I'll try to get back to you, Maria, on that one.
Okay.
So there are a number of psychiatric concurrent conditions in autism. So the most common one, in addition to ADHD, is anxiety. Anxiety has 42 to 55, 56%. And there's obsessive compulsive. The second one, I would say, is oppositional defiant disorder. And then there's depression, which we don't see. There's depression in little kids, but is much more prevalent in adolescents. Then we have OCD, and there are these substance use disorders, psychotic disorders, and eating disorders that are much more frequent in older kids, not the kids that you get to see. So I have another table that shows a series of 658 kids with autism from 3 to 17 age with a mean of 7.2 that were referred for hyperactivity to a psychiatric clinic. And the prevalence of ADHD was 1%. So, but these are kids that are referred to psychiatry. The prevalence of oppositional defiant disorder is 46%, anxiety 42%, mood disorders 8%, and conduct 12%. So this, I want to show interaction, which is so complex, and this is a busy slide, I apologize for that. But these are the kids that had ADHD in pink. Oops. The pink are the kids that have ADHD. This one is oppositional defiant disorder, and the clear one is any anxiety disorder. And you can see that 24% of all these kids had the three of them. They have oppositional defiant disorder, anxiety, and ADHD. And then you can see that 17% kids had ADHD and anxiety. And 21% of kids had ADHD and oppositional defiant disorder. And so you can see that there's a lot of overlap on these conditions. And it's just like a small percentage of kids, 28% that only have ADHD, 2.7% of kids that only have anxiety, and 3.1% that only have defiant disorder. So this tells you an idea of how complicated this can be. So the most common anxieties are social anxiety disorder and generalized anxiety disorder. Something to keep in mind is that the high functioning individuals are the most susceptible to anxiety problems. The older they are, the higher the prevalence for anxiety and mood. Something I want to still, there are some kids that are not high functioning that still have anxiety. So what does anxiety do to people with autism? It aggravates their autism symptoms. It interferes with treatments like ABA, speech, occupational therapy. It causes irritability, outbursts, self-injury behaviors. It increases parental stress. It tells you that they are at risk for long-term psychopathology. And also, as you get older, influences the transitions to adulthood. So what are the common presenting symptoms of anxiety? And you may recognize some of these. Just seems on edge all day, yelling at people at work. This is for older people. Doesn't like loud noises. We can't go anywhere. Really scared of getting his hair cut, having meltdowns all day, looks time, and interested in making friends. So this is a busy slide, but I want you to look at this. Any disorder, any psychiatric disorder, 70% with autism. Any anxiety, 41%. And the anxiety is the generalized anxiety disorder. It's like worries about different things, like in specific worries. But look, the social anxiety is 20%. And the Obsessive compulsive disorder is 8.2%. So those are the numbers that I wanted to highlight. Anxiety, generalized anxiety disorder, separation anxiety, social phobia, obsessive compulsive disorder, and there's also post-traumatic. Something that is really important to keep in mind is these ambiguous presentations, which is not in DSM-5 yet. And this is a slide about ambiguous anxiety. Anxiety that is linked to the core autism symptoms. And so there's excessive fear. So these are the symptoms of autism, but with heightened anxiety. Excessive fear about rules and change, social fearfulness, worries related to intense preoccupations, specific phobias. These are some examples of fears. And so that tries to contrast anxiety versus autism, like social avoidance or disinterest. People with autism are not socially motivated, but people with anxiety, they may have fear of social situations. Now, like I said, there are people that have autism and anxiety, so you may see both. Repetitive behaviors. They're pleasurable, but in anxiety or in compulsive people, it's stressful. Perseveration. People with autism, it's just repetitive speech, but people with anxieties have true concern and worry, and they perseverate in their head about that. Reactions to change. In people with anxiety, there's a lot of anticipation of change. Autism, there's not that much the anticipation anxiety, but there's a need for sameness. They need that sameness. And people with autism have a lot of sensory overreactivity, and people with autism, sensory reactivity, but people with anxiety, they may have a lot of anticipation, agitation before the sensory trigger. The affect, there's reduced affect modulation, there's some flatness, there's a lot of worry and depression, a lot of behaviors a lot of the behavioral outbursts of autism are attention seeking or are escaping, and in people with anxiety, it might be more like clearly in response to an anxious trigger. So what to do with people with anxiety? So modified cognitive behavioral therapy is the way to go for people with autism and anxiety. But they need to have at least 70 of an IQ. They need to have, it doesn't work in people with intellectual disabilities because they won't be able to get it. And it works for different types of anxiety. Ideally, it should be 12 to 16 weeks. And in these therapies, there are general concepts of stress and feeling upset, identifying anxious situations, graduated exposures with reinforcement, self-regulation strategies, limited cognitive restructuring. So that's what they teach these individuals. So for people that have don't have access to these therapies, there are no resources, or they have or an ability to take advantage of the cognitive behavioral therapy, you can try just behavioral interventions that provide graduated exposures and reinforcement, teaching relaxation strategies, boost communication strategies, and do modeling in these situations. And, anxiety requires therapy, but a multidisciplinary treatment, assess levels of support with social work, improve communication, address strengths, and sometimes medications. So medications for anxiety are recommended for individuals with autism severe anxiety. And you know, if you look at the prevalence of per age, you see that younger children have the lowest prevalence of anxiety. Still, there are some 4 and 5-year-olds that have so much anxiety that after you treat the cognitive behavioral therapy, the communication, there's still anxiety in these kids. It's not common, but it happens. And in those cases, you may consider with the family, of course, doing one of these interventions. It's not easy to treat. It's not, you know, it's a hard step to do, and we don't do that very often. But sometimes that's something that you have to do. Some other interventions that you can do for these families is try to sleep, because anxiety can cause sleep problems, and sleep problems may make anxiety behavior worse. So you can try melatonin. You can look at physiological arousal. A lot of kids with autism that have anxiety are very dysregulated, have a lot of arousal. So you can do guanfacine. And sometimes there can be behavioral dysregulation. You can treat clonidine and guanfacine, but eventually, particularly if these kids have significant dysregulation and self-injury behavior, and they are making really the life of everybody really in themselves very disruptive, you may have to consider what I call their option, which is trying like Risperdal or Abilify. There are that you have to go there. Ideally, I try to stay away of that, and sometimes I have found that doing the anxiety medications can prevent going to Risperdal or Abilify. For some families, it's more skilled to do this, but in my physician mind, I'd rather do SSRIs than Risperdal or Abilify, because these ones the side effect liability of this is better than this. If they tolerate this medicine. The thing is, there are many kids with autism that may have don't tolerate these medicines well. But the problem with the Risperdal and Abilify is that they can cause weight gain, all the risk for diabetes or for metabolic problems in the lung. So that's that's a word about that. The more common in older children, but sometimes we can see in younger children, and we need, particularly when they're irritable. A word about obsessive-compulsive disorder there's a lot of overlap with autism. To differentiate, that is not always that clear-cut, is that repetitive thoughts that do not involve intrusive anxiety-causing thoughts or obsessions is usually part of autism. OCD is a lot of anxiety associated with these repetitive behaviors and thoughts. The thing is, sometimes you have both, but sometimes you can have like a more clear differentiation. And I want to wrap up with oppositional defiant disorder. Oppositional defiant disorder is very common. Could be a manifestation of anxiety, resistance to change, stubborn belief in the correctness of point of view, difficulty seeing another's point of view, poor awareness, or no social compliance. You see that in 2 to 15% of children in general, but it's, like I mentioned before, it's more common with autism. And see a pattern of non-compliant and defiant behavior towards authority figures. Usually you see more verbal than physical issues. There's reactivity to limits and frustration. The problems in ODD kids can be in the community, school, or all of three, but they don't need to be in all of three. I've seen some kids that have a lot of anxiety that behave fine at school and are very challenging at home, and they still meet criteria for oppositional defiant disorder. It usually happens before age 8 and happens more in boys than girls. There's a lot of overlap between ADHD and ODD, but also anxiety. So in many cases, ADHD is behind the ODD. In many cases, anxiety is behind the ODD. Like I show in the graph, sometimes both are behind the ODD. And there's only like a 2 to 3% of kids that just have ODD without an underlying condition. So what are the symptoms that you see? You see the angry, irritable mood in these kids that are losing their temper often, they are touchy and easily annoyed, and resentful. They can be argumentative and defiant, deliberately annoying others or blaming others for problems. And sometimes you can, particularly in older kids, you can see this vindictiveness. Okay, so, oops, okay, so I'm gonna keep going.
Right, we have just a couple minutes left, so, you know, just to catch up on the last couple of slides.
Okay, so I wanted to show you a little bit about the behavioral concurrent conditions, which are aggressive behaviors, which is very disruptive to schools and to families, self-injury behaviors, and Spica, which we already talked about. So sometimes you see aggressive behaviors to to family members, but it's really disruptive when the aggressive behavior to other kids. Self-injurious behaviors are associated with impulsivity and hyperactivity, negative affect, and lower levels of ability and speech. So the target is for treatment when kids present a lot of self-injury behaviors and dysregulation. Again, looking for a medical comorbidity that we have mentioned before. Look for the core symptoms of autism, with treatment like ABA. We can never overemphasize the connection, communication, and behavior. So like speech therapy, allowing these kids to communicate. And sometimes, you know, there's no speech. Some of these kids cannot talk. So it's really important to think about augmentative communication interventions. Using PECs or augmentative communication device can be really helpful to address behavioral issues. Even though a lot of problems from these kids come from their own autism, we should never underestimate the impact of psychosocial stress. The structure and the family treatment is really important. You know, there's a lot of families that have a lot of stress working with kids in general with neurodevelopmental disabilities. So it's really important, particularly, and I always emphasize when I do my consultations with CFC-11, I'm the medical consultant with CFC-11, the role of social work in working with families and trying to help them their own challenges and how they can have such a big impact. And then the psychiatric comorbidities. It's really important to think about some of these kids. You can do all the things that you have to do, but if the kid has a severe anxiety disorder or a severe ADHD, you may have to do like a pharmacological intervention sometimes. And again, you know, as a pediatrician, I'm very conservative about medications, but sometimes you have to go there. I think time is up. I have a couple of questions that I would like to answer via email, so I'm gonna email Maria to answer those questions. And but thank you for your attention.
Thank you so much. If you wanna address Jamie's question about anxiety in young children becoming causing children to become more aggressive.
Yeah, let me see. Does the medication for anxiety in young children cause the young children to become more aggressive? That's a great question. Sometimes. So in general, the goal of doing an SSRI in a young children with anxiety is to decrease the worries, make them more relaxed, make them more and less aggressive and improve their overall functioning. But it's common to see some young children, when they are exposed to these medications, that they become more irritable and sometimes more aggressive. So it can be a side effect, and it's not such an uncommon side effect in young children. So we usually, when we start medications of that nature, we start with very minute doses, and small doses, and we build up gradually until we find the sweet spot, the therapeutic window. Thank you for that question.
Thank you. So as Dr. Ochoa said, he'll email me some responses to the other questions, and we'll make sure that those get out to the participants of today. Again, I want to remind you that you will get an email from the EI training program. I've been told it'll show up around 11. Just complete that survey in that email, and then you will get your certificate of attendance. If you did participate in a group, remember that you would have had to have been registered individually in order to get that individual email. Also, I want to thank Doctor for presenting. It's a lot of information. There's just so much information out there related to autism, and trying to fit it into a 90-minute slot is always a challenge. As you can see on the screen, I have the upcoming webinars listed, so please check those out. We look forward to bringing those to you every winter, and from all of us at EITP, thank you, and have a good rest of your day.
I guess that's it.
Okay.